Hello, my name's Joe Scott-Jones. I'm a GP in Apodiki, Chair of the Rural Health Alliance and Chair of the Rural Chapter of the New Zealand College of General Practitioners. And I'm here on the couch with Anne Hendry, Clinical Lead for Integrated Care from NHS Scotland and a geriatrician in Hamilton at the college conference. Hello, Anne. Tell us a little bit about yourself.
Thanks very much. I'm delighted to be here and take part in the conference in Hamilton. My clinical background is a geriatrician and stroke physician, but probably for the last 5-6 years I've been working nationally across Scotland supporting the Reshaping Care for Older People programme, and then that's gradually evolved into integrated care for all adults,
right,
with a particular focus on supporting people with complex care needs. So that's adults with multiple long-term conditions, combination of physical and mental health problems,
yeah,
and looking at how we might use technology to enable that integrated care and support.
So the integration is across the
health social care, housing, with the third sector and also some of the independent providers. And we're also very much conscious of health needing to be integrated across primary care, hospital care, mental health.
So tell me about the information technology and how that is being utilised in Scotland to aid the integration of care.
We're describing the technology as being an enabler. In a sense, it's potentially really quite a disruptive innovator, a real catalyst, a real game changer if we get the use of technology right. We've been on a journey with the use of technology. We've had probably about 8 years ago, we launched a technology programme around telecare. And that was particularly adopted by our local government, our local authorities, in terms of providing the sort of assisted living technologies in the community. And we more recently converged that telecare programme with our telehealth programme, which was looking at some of the simple home health monitoring for COPD or heart failure, as well as some of the video conferencing facilities to provide remote decision support. And so more recently we now have a more sort of comprehensive telehealth care programme, and we're currently aligning that better with our e-health programme, because there's a clear interdependency between all of that. I think telehealth, it refers to the sort of video consultation or the home health monitoring kit. Telecare is much more about the practical supports that people might need to take part in normal activities of daily living, like the community alarms, the flood fire sensors, the wandering monitors, things like that.
Okay. And Scotland, like New Zealand, has huge distances and very remote and island communities. But how on earth do they manage with integrating telemedicine when, I mean, presumably you have the same sort of problems with broadband access that we have here, or internet access here? Yeah,
and the broadband coverage is an issue. I mean, that's been referred to several times over the conference here, and it's similarly an issue at home. At a strategic level, we've got a digital strategy which has been aligned with our telehealth care strategy, so that we've got cross-government support for the rollout of broadband coverage in Scotland. Still got a bit to go, but you know, there's a clear plan in terms of that rollout. We're also exploring some more creative options, like looking at the use of some satellite systems in some of our areas.
What about emergency services and telemedicine? Is there
We've got, particularly in the northeast of Scotland, in the Grampian area and covering some of the island boards, we've got an unscheduled care network which is providing some of the emergency response, so connecting perhaps an island community with an A&E consultant on the mainland who's able to look at some of the X-ray imaging that's being done and, you know, give some advice or reassurance or professional decision support to say, no, this needs to be transferred. and that's now really quite mature in terms of people's understanding of how it works, people's confidence in how it works, and patient and carers really quite confident and reassured in using it. The other way that connects is with some of the community hospitals on the mainland that are at some considerable distance from the District General can use the video conferencing and transfer of imaging to save a round trip of maybe a couple of 100 miles.
Yes.
And we know that that's not a good thing for older people to have to sort of transfer that distance. As well as a geriatrician, my subspecialty interest was stroke, and for a number of years we've been working across Scotland in developing stroke services, but also trying to look at the rollout of thrombolysis.
Yes.
And so we have CT imaging capacity on island, but we don't perhaps have a stroke clinician on island who's able to respond out of hours to an emergency. So we've got a network established that somebody can be CT'd and then the image transferred, and a stroke consultant on mainland will be able to look at the CT and again make the diagnosis about whether or not the person's appropriate for thrombolysis. But I think the thing that I've been struck by is it's not just a rural agenda.
Yes.
My clinical practice as a geriatrician was in an urban setting, but the patients don't travel well. The population of patients who are complex dependent and at high risk of delirium if you move them.
Yeah.
So there's something for me about we need to make more use of the technology even in an urban setting.
Yeah.
Some of our examples of video conferencing into care homes.
Yes.
We've explored that in Highland remote communities and done sort of perhaps community psychiatric support at a distance to the care home to help manage antipsychotic prescribing,
Yep.
reduce benzodiazepine use, and give advice to the care home in managing people with complex behaviour support issues.
Where would you say that you are on the Gatner curve? Are you in the peak of expectation, or are you in the trough of experience, or are you climbing out of the trough into a sort of more of an effective longer term?
I think we've gone beyond the peak of excitement.
Right.
We've probably dipped a little in that you realise that the enormity of the challenge of spread, but we're coming back up because we've been able to, which is fantastic news, we've been able to leverage some additional funding to support scaling up.
Yes.
We've got £10 million for the next 3 financial years, which is going to go quite far in terms of supporting adoption of probably, if we focus on a few things that we know that there's good enough evidence and we just need to spread them. So we're focusing on more of the video consultations and using that beyond health, so looking at, health into care homes and other social care settings, looking at scaling up some of the simple home health monitoring, not very complex kit, but some of the light touch monitoring that uses available day-to-day technology for SMS messaging and symptom control feedback. And then finally looking at probably some further adoption and spread of the telecare equipment, recognising that there's now good evidence that is delaying, if not completely preventing, institutionalisation. We've got some decent studies from some of our health economic colleagues that have worked with 1 or 2 of our partnerships to look at the cost avoidance of telecare in a dementia population.
Right. It's useful to have an outside perspective on how we're doing. Where would you say we were?
My sense is that you've got lots of enthusiasts and that you've got quite a number of tests and pilots, but perhaps not quite got to the systemising of it.
Yeah.
And certainly our learning has been that the redesign of the system is as important, if not more important, than the actual implementation of the technology.
Right.
So it's all very well having wonderful telehealth equipment, but unless you've redesigned the way processes around that are implemented, then you'll not maximise the outcomes.
Yeah. So one of the key things was aligning the digital strategy with the health strategy and what you're trying to, and the impact of telehealth.
Yes, but also not just at the strategic level, also at a very operational level, that introducing home health monitoring for COPD in a locality isn't going to make a difference in emergency admissions unless you're connecting that with the front door processes and what happens when people call an ambulance.
Yeah. Yeah.
So joining up the pathway, embedding the technology within the pathway.
So just finally, if you had a few words of advice to give the National Health IT Board and the people that have control over our digital strategy and implementation of technology into to help integrate care in New Zealand, what pearls would you cast before us?
I think I would say it's a long game,
Yep.
so don't expect instant results, but there's now compelling evidence from across the globe that technology gives greater choice, control, it empowers individuals, and if we're really trying to build resilience in individuals and in our systems, we must do this.
Yeah, we must do it. It's an inevitable thing, really.
Absolutely.
Thank you very much, Anne, and thank you
Pleasure.
for coming all this way. It's a long way to come. So,
Pleasure.
Thank you.